thank you. So let me begin just by saying it's truly an honor to be here and to have been invited. So thank you to Dr. Riley, and a special thank you to Dr. Young-Hyman for inviting me to be here today. So by way of overview, I will begin by talking about healthcare transformation and the role of behavioral and social sciences research. I'll move on then to the context of transformation and behavioral and social sciences research in the context of diabetes specifically as a priority condition. And then I will go through 3 examples of interventions that have been or are being integrated into care. So let's start with healthcare transformation. All of us who are in academic medicine, and to all in the audience who may be a part of healthcare organizations, any practitioners are very well aware that we are in the midst of transformation and innovative initiatives in healthcare. And the overarching goals of transforming care as we move from volume-based to value-based care are to be able to optimize our performance along all 3 of the dimensions shown here, known as the triple aim. Improve the health of the population while improving the patient experience of care, while concurrently decreasing the cost of care. So as we go through this transformation to value, some of the core themes that are involved are within the health of populations, healthcare organizations and practitioners are being held accountable for all people within an attributed population. So not only patients who are coming through the doors and coming regularly, not only those who are adhering or performing well, it's everyone who's attributed to that practice site or geographic location. In addition, because of the accountability to the entire population, we have to pay attention to the distribution of outcomes in the population, which automatically brings the theme of health equity. And as we know, for diseases of health disparity, that distribution of outcomes is inequitable, with populations of health disparity, which are often racial and ethnic minority groups, lower socioeconomic status groups, having poor outcomes. And so in this transformative era, we're seeking to improve health equity. As part of this theme, we have to be able to provide the right care in the right place at the right time. And so that means we have to ensure access to care, but also the right delivery models for care and the right workforces. And finally, there's a focus on performance measurement and incentives. That means that interventions need to be evidence-based and they must work. There's no time and no luxury of trial and error for healthcare systems who are trying to meet the demands of care, quality metrics, and costs. So I contend that behavioral and social sciences research is uniquely positioned, and it is in demand. Healthcare organizations and stakeholders are actively seeking the work of behavioral and social science to help meet the needs of transformation. And so what does behavioral and social sciences research do? It contributes methods for understanding and modifying behavioral and social phenomena relevant to health. It addresses the central role of behavioral and social science factors in achieving performance outcomes. It addresses the needs for multi-level and multimodal change, and particularly not only in individuals, but in organizations. And critically, it brings the empirical science and the evidence for effect and reproducibility. And so I'm going to direct your attention to this figure. Now, although there are many theories of behavior, it's important to recognize that behavioral and social sciences research starts as basic science research and empirical science. What's important about that is that the basic behavioral and social sciences research contributes knowledge of underlying mechanisms and processes of behavior. This research, of course, starts often with animal models, organisms. It includes neural systems, what's driving behavior. And that informs the development of evidence-based interventions. Those, what we know about underlying mechanisms then gets applied based on context. And so it may be applied to different health behaviors. It may be applied differently to population subgroups or to different medical conditions. Being able to utilize the basic science mechanisms and apply it to interventions depending on context enables a specificity and an appropriateness to the interventions that are delivered. And that is how we make population impact. So many behavioral and social sciences researchers work very closely with public health practitioners, and often public health use a figure to the left that looks a little bit different. It starts with applying interventions to a large population in order to have a population level impact. I think behavioral and social sciences research sometimes is misunderstood and gets knocked because generally we will start with not a population, but an organism and how those mechanisms work for an organism. And from that, we build to produce the specificity and then have population impact, but not by applying the same thing to the whole population. And so that applying to context allows us to improve the health of defined populations. That specificity and appropriateness is where we start to achieve goals of equity. Importantly, it also is how we get to patient satisfaction. Patients want treatments and interventions that make sense to them, that work for them. And when patients are getting what they need and what they're seeking and what's working, they are engaged. And ultimately, we can hit those health and cost of care impacts. So the question is, what facilitates the integration to practice of the interventions that are available? There are hundreds of thousands of successful behavioral social science research interventions that have been published and that are sitting, I used to say sitting in libraries on the shelves. Well, not so much now. Now they're on a disk somewhere or some digital thing. But there is, we know a great deal. A lot of research has been done, and little of it, though, gets integrated into routine care or practice. So these are some of the factors that facilitate. And as I go through today, I hope you'll join me and agree and see. I start with proven intervention. What I mean there is that because behavioral and social sciences research really does start with evidence, we're talking about interventions with evidence. But they must solve a problem of import and scale, and there must be economy of scale to make the adoption of that intervention worth the systems level and organizational change. Second, the intervention does need to be designed as usable and effective with the patients who are most in need of the intervention. Third, it must hit outcomes that align with targets for healthcare and public health organizations. It must enable standardization at the same time being amenable to flexibility, and sometimes people think that this is a duality that can't be achieved, but we need both. There are aspects of standardization and then flexibility in applying. So, diabetes as a context. So I said one of the criteria for adoption is a problem of import and scope. Diabetes is the most expensive healthcare condition to our healthcare and public health systems. 5 years, the American Diabetes Association publishes the national data and analyses on economic costs of diabetes. The most recent was 2017, $327 billion a year was the total economic cost of diagnosed diabetes. The cost attributable to diabetes is 1 in every 7 healthcare dollars, and the costs incurred by people who have diabetes is 1 in 4 healthcare dollars. So anyone who's listening who works with an insurance company or a healthcare practice or system knows that diabetes is a priority condition affecting your population, and so there's pressure. At the same time, although there are very high costs of diabetes in healthcare, we have not seen improvements in care. And here, these lines are indicating the percentage of, this is commercially insured patients with an A1C of greater than or equal to 9 in the red bar and less than 7 in green, despite the fact that we have had tremendous advances over time in treatments, therapeutics, technology, equipment, devices. Those lines have been flat. I don't know how many of you saw the JAMA Internal Medicine article that was published just a few weeks ago, but more recent data ending in 2016 show the same pattern. Although there is consensus now about the types of goals that we seek to achieve in healthcare for diabetes, there have been no significant improvements, and gaps that have long been known due to socioeconomic status persist. So there's work to be done. I am at Johns Hopkins, so I'm in the state of Maryland. Anyone in the state of Maryland is affected by the fact that Maryland is a leading state for transforming healthcare finance models in order to reduce the growth in healthcare spending. So since 2014, we have, with CMS, had new payment models that have been tested. As of 2019, we're now on the total cost of care model. As the growth in healthcare spending is being reduced or contained, it's done via incentives and disincentives, but more importantly, there is an accompanying strategy, set of interventions that are done in order to improve care, and that is called a population health improvement strategy. The state of Maryland chose diabetes as its first statewide strategy for population health improvement in order to meet the needs of our total cost of care model. So let's talk about some examples of behavioral and social sciences research in interventions in diabetes that have pathways to integration, and then we'll talk about what we can learn. So the first is the Diabetes Prevention Program Lifestyle Change Program, and this likely will not be new to anyone in this audience. The diabetes prevention is a part of the Maryland state strategy because although we're talking about healthcare and healthcare costs and financing, and we know a lot about our managed populations with diabetes, ultimately, if we really are going to improve the population level health and costs in diabetes, we have to present it when we can. So let's start with the science, because all behavioral and social sciences research begins with some base of evidence. And this is the classic figure from the original Diabetes Prevention Program trial, which found that metformin did produce a 31% reduction in incidence of type 2 diabetes in a population at very high risk for type 2 diabetes. And lifestyle produced a 58% reduction, cut the risk in half. And that was done via very modest goals, a 7% weight loss achieved via 150 minutes of physical activity a week, often 30 minutes of brisk walking, and very targeted nutritional changes. Rena Wing was awarded the American Diabetes Distinguished Behavioral Science Award several years ago for her contributions to ensuring that the lifestyle intervention implemented in the DPP was based on basic behavioral and social science principles and the evidence to date about change. Very often, as you all know, lifestyle interventions may be designed with an inadequate dose, or with inadequate duration, or with inadequate content. And it was critical for this trial that that not be the case. Hence, we had a fairly intensive intervention, but that was based on what works. Sometimes what's forgotten with DPP is that it also, via behavior change, improved these cardiovascular risk factors. It reduced hypertension and dyslipidemia. And this slide just shows the triglycerides, HDL, and LDL, all of which improved with lifestyle intervention. And so as healthcare systems are, for example, costing out the potential benefits over time of diabetes prevention, those cardiovascular risk factors are also important. Not only was it effective upon conclusion of the trial, but at 10 and at 15 years after the trial, of course, we've continued to see benefits in prevention or delay of type 2 diabetes. In 2009, the Diabetes Prevention Act went into law, and this was critical. This was because of the overwhelming evidence, and when this passed the House of Representatives, it essentially said that all people who are at risk for diabetes should have access to a diabetes prevention program. And the Centers and CDC was put in charge of establishing the national program. So in terms of a national program, because this is where we really start thinking about integration, what are some of the things we can learn from that? Well, first, CDC brought standardization with flexibility. So there is a standardized structured curriculum, again, that matches the evidence base for dose, duration, and content. But it established a new workforce, DPP lifestyle coaches, and that DPP lifestyle coach designation comes with a training and certification as a DPP lifestyle coach. There are specific performance measures and reporting requirements to ensure programs are performing up to the expected standard. Critically, it uses community-based intervention settings rather than relying solely on healthcare to address this need. And all of this is rather unprecedented, but something perhaps the most surprising, particularly when I talk to healthcare providers, is that insurance reimbursement from CMS is not for healthcare providers only. It goes to the DPP lifestyle coaches and community-based settings that are delivering the program, and that's critical. And so we also have to make sure that our interventions can work for people most in need, right? This is simply from one of the CMMI awards, which examined DPP in a Medicare population specifically. Now we tend to say a 5 to 7% weight loss as the target for the national DPP. And they did find that in the Medicare population, the 5% weight loss goal was achieved, but they also found cost savings for people who were enrolled versus those who were not enrolled but eligible for DPP. Medicaid demonstration for DPP has wrapped up not too long ago. Johns Hopkins was one of the sites for the Medicaid DPP. And I just want to show you, these are some unpublished results. It takes a while to accrue results from in-person DPP groups because there are about 15 people at a time. So what I'm showing you is just a sample of performance from our Roncati Center DPP programs. Now, these are specifically in Baltimore, in low-income neighborhood sites. They're churches, church basements. They are federally qualified health centers, predominant racial and ethnic minority, and as you see, about 51% Medicaid here. And what we see is retention over a year. Again, the program is still 12 months. It's 72%. Attendance, 86%. And have our folks been hitting the weight loss goal? Yes, they have. 5.6% average at the 12-month period. And as it says, this outperforms the national benchmarks. And so all this is to say, as we talk about context, it is certainly possible to ensure that you are appropriately supplying something like the DPP to populations who are most in need. I'm going to talk about a second example now. So as we look at the diabetes care quality measures, we are looking at populations of people who already do have diabetes and what can be done to help improve their outcomes. Diabetes, as you all know, is a disease that is heavily reliant upon self-management and behavior and regimen behaviors of the person living with diabetes. And DECIDE is a program that's designed and tested for that. So the purpose of the DECIDE program is to develop an evidence-based module. It's a 9-module structured curriculum that provides both knowledge, which is essential for self-management, but it also provides behavior change training, and that's done through problem solving in order to enable long-lasting skills. Like the DPP, which is able to show benefits long after the original intervention, it's important that people have skills they walk away with and are able to continue to utilize in order to have long-term benefits. And so in designing DECIDE, there were a few things that I sought out to do with our teams, and that was to use our science of behavior change and evidence-based approaches. Often these are being used routinely by behavioral clinicians in care, but we want to translate that into what can be replicated and disseminated on a larger scale. And again, where I'm based and where my research environment is within an urban, inner-city, low-income community population. And so I know that I would need to address the needs of high-risk patients in need of intervention. And so why problem solving? Back to the fact that there's basic behavioral science that underlies our work. Problem solving is a long-standing approach, evidence-based approach to behavior change, and it originated in several of the fields of psychology, cognitive psychology, social problem solving. It's a part of education and learning models. And I published what some people call a treatise, 2003, time passes quickly, about problem solving as a model for chronic disease self-management, using diabetes as an example. But by taking into account the various disciplines that have contributed evidence to diabetes, there were 4 essential components that are needed. Yes, knowledge is needed as a prerequisite for problem solving, but you also need instruction and training around style, orientation, and being able to transfer past experiences and learn. And we also know that our populations have a lot of challenges and barriers to care, which make problem solving relevant. As I said, the population most in need in Baltimore is very similar to populations in other high A1C risk strata that healthcare systems encounter. Often, they may have lower socioeconomic status, there may be limited literacy or health literacy. If people, of course, have had diabetes that has not been well managed, usually there are comorbidities, there are complications, very often accompanying functional impairments, and psychosocial comorbidity. As a result, there are many foundational things that need to be built in to the interventions we're designing, including material disseminating that often are not a part of our routine practices with research or clinical care. And so some of those are listed there with a check mark. Literacy adapted, organization of information for ease of information processing. Again, cognitive psychology tells us a lot about how people learn, what's effective, what's not, what makes it into long-term storage, and what does not. And so our course of research in intervention development had to address all of these design issues. And so I'm putting up a few slides just to let you know that there are many resources available, methodologies for ensuring readability, particularly to people with low literacy. But it was also important to test that these methodologies worked, back to the importance in behavioral and social sciences research to be evidence-based. There are many instructions about designing information for the highest level of information processing that also make materials easier to use for people who do have functional impairment and disability. And so we, of course, needed to test that out. When we combine the design of materials and programs to meet those population needs with the problem-solving based intervention program, we've been able to test dose. And even in our, I think in one of our first trials, over 50% of our population was living in poverty, had poorly managed diabetes for 5 to 10 years or more. And we were able to see a very significant reduction in A1C and improvements in behavior. We've also, the need for testing in different modalities led to this trial that I'll just show some results from, in which we wanted to see whether, we often use in-person groups, which is lovely when that's available, but what if people had to do this on their own? Are the materials well enough designed that people can achieve this themselves? Or what if it's done one-on-one? Some healthcare systems or clinics do have access to educators and resources who can do it one-on-one. And we found that, yes, it was effective in each of the modalities. And when we looked at patients who had A1Cs above 7.5, you see they really were starting at 9.5. We were able to see very significant reductions despite modality. And just like in DPP, if you're engaging people in lifestyle behavior change, even if the original goal is glucose, you will very often also be able to see benefits in blood pressure and lipids. And behaviors. Behaviors, of course, are the mediator. And so a question that was asked to me was, can DECIDE be applied to other high-risk populations? So what we have is a disease-specific self-management education, because knowledge of self-management is critical, but not sufficient. And then we have a standard problem-solving training based on basic behavioral science of problem-solving that is disease agnostic. Can that be applied to other populations and contexts and different workforces? So my research, of course, has been urban African Americans with low socioeconomic status. A CDC cooperative agreement tested the DECIDE intervention in rural populations in 3 states, and these populations were multi-ethnic: white, African American, Hispanic, Spanish, English speakers, not Spanish speakers, and Native Americans. And the endpoint here was behavioral. This was for cardiovascular disease prevention, and they found the problem-solving intervention effective for those behavior changes. This next study, ACT, was a primary care clinic-based delivery of it for primary hypertension, for reduction of blood pressure. And at Geisinger currently, this is a chronic kidney care version of Decide being used in rural Pennsylvania in people with chronic kidney disease. There's also a mental health version that's currently being tested. And so I tend to think of this as, if there's a strong foundation that comes from the evidence and basic principles and laws of behavior, it can be applied in different contexts. So the final example I'm going to go through quickly is the collaborative care model for mental health integration. I put primary care in parentheses because, again, to the point of standardization yet flexibility, it's not only for primary care. So we know that in diabetes, there's a great deal of psychosocial comorbidity. The collaborative care model really comes from the University of Washington and a group of Wayne Caton, who's now deceased, and his research team. And it involves shifting the model of care in order to provide some standardized workflows and evidence-based interventions to people who present for medical care but have comorbid mental or behavioral health conditions. There is, I've put here some examples of the evidence base for collaborative care, specifically in the context of diabetes, but there were probably 35 to 40 trials before diabetes that demonstrated that collaborative care is highly effective with older adults, with people with depression, with people with primary anxiety disorders. I'm a behavioral researcher in diabetes primarily, so I like to say that it was when Wayne Caton's group applied this model of care to diabetes that attention to this model really was drawn, and it became recognized because they were able to demonstrate not only did they improve behavioral outcomes and depression and mental health outcomes, they also improved diabetes outcomes. So there's a collaborative care workforce, and this is from the Medicare Learning Network. Medicare now reimburses for collaborative care. There are team members. There is a treating or billing practitioner, which is a physician, but notice all the and/ors to the point about flexible workforces. There is a physician, a provider, a medical provider, could be a physician or one of the nurse providers, PA, and most often it's in primary care, but it could be in cardiology, could be in oncology, could be in endocrinology. And there is the addition of a behavioral health care manager. Now notice, this care manager could be a social worker, could be a nurse, could be a psychologist. There's a psychiatric consultant who provides consultation to a panel of patients who are in the medical practice, often will make recommendations and do the prescribing of titrating medications or intensifying medications, while the care manager is doing the close follow of the panel of patients. It uses very structured measurements and tracking of outcomes on a weekly basis to ensure people are moving towards goals. I will refer you to the University of Washington's Ames Center website, where there is a great deal of information available about how the standard, I call this part of the standardization. They will walk you completely through how to implement collaborative care. There are trainings for the workforce, again, a theme that recurs because it's not just one type of professional. There's a training in how to do this model of care that, irrespective of your professional background, you must be trained to do this. And finally, just to remind, Medicare is now reimbursing for collaborative care. So in conclusion, I'm going to go back to some slides from the beginning. Behavioral, if we are working towards greater integration of our behavioral and social sciences research into practice, we know that the evidence for it and the evidence base is critical. It must solve a problem of relevance right now, and it has to be able to reach a scale that makes the adoption worthwhile and work. We all know how difficult behavior change is, and on an organizational level, it's very challenging as well. So it must have some economy of scale. There are many priority issues out there, though, so we are not hurting for issues and problems that require BSSR. It has to be able to be used with the populations most in need, and that has implications for how we design our materials. It does need to be able to hit outcomes that are consistent with targets that our organizations that we're asking to adopt the intervention are being held accountable to. And most critically, perhaps, it has to have standardization, meaning there is specific content, there's dose, and there's training for reliable delivery, but it must also be completely flexible in terms of workforce that can utilize it so that it fits any resource, delivery models so that they can fit any setting and the resources for that setting. And these are not impossible things to do, we're finding. And finally, back to this diagram, the standardization happens early, which is why the basic behavioral and social sciences research and the prior evidence are critical to us. It is those foundational principles that are standardizable. Those are what the things we know work for organisms, living beings. The flexibility comes as we do the modifications for context, and then the scaling occurs as collectively we're able to apply with specificity and appropriateness what's needed. And I'll end with what's needed from BSSR. We need the ability to answer the stakeholders' question, what works? Someone from an insurance company asked me, so if I'm going to do one thing with my already staffed care managers, what would that be? What would that one thing be? What's that one intervention? We need to be able to answer questions of, so what is it? What works? What's the most important thing? And what works reliably, of course, for those various contexts. We, the behavioral and social sciences research community, need to be able to provide the tools and resources. A healthcare system and insurer is happy to bring a trainer to train their case management workforce, their community health worker workforce. But we need to have those repositories of interventions that are easily indexed. I put here ADA self-management support. It has started a repository now of evidence-based interventions. I don't know if they've launched the website yet, but it will be coming very shortly. We have to understand the various workforces. There are things that are generalizable to workforces with training, but then there's specific things that professionals and specialists still need to do, and no one's asking us to stop doing our roles and jobs, but in addition, we also have roles of training and bringing successful interventions to broader workforces. And finally, we must provide those workforce competencies and ensure fidelity in intervention delivery. So thank you, and I just want to acknowledge for the programs I chose to feature today, the sources where you can get all the information you need for delivery and implementation. And I want to acknowledge that for DECIDE, I'm very appreciative to the many organizations, including Kaiser and Geisinger, and all of the investigators from other places around the country who are doing the work in that context application. So thank you.
Thank you, Dr. Hill-Briggs. That was really excellent and inspiring. And as you might imagine, wonderful to see the application of all the work that's happened in the diabetes community and how it really applies to other chronic and costly diseases. So very exciting. I'm going to manage the question and answer, and I'm going to open it up to those in the room, see if anybody has any questions, and then I'll shift to the chat box. Just as a reminder, if you want to ask a question or send a comment, click on the Q&A on your screen as all panelists and type in your question and then send it, and that way we'll be able to see it. We probably won't get to them all, but we'll get to as many as we can. So.
While we're waiting, can I jump in first? So, Felicia, this was excellent. The couple things that stick out to me that I think are really important, and I'd like your thoughts about how to facilitate this in places other than in diabetes where it's worked so well, right? One is the linkage to basic science and ensuring that those principles are in place. Sometimes we end up funding research where we don't see those basic science principles being as strongly grounded in the intervention that gets proposed. And then the other side of this is DPP and other programs decide, and those have done a really nice job of getting these things implemented and used in the field. But like you said, there are thousands of these, and so what's the difference? What's, in your view, what's unique about what's worked and what hasn't in terms of that implementation process?
I think so. It's hard to know what's different with the numerous available interventions out there. What I have observed is that number one, that intervention really needs to speak to the stakeholders. It needs to speak to healthcare organizations. It needs to speak to those populations that providers are struggling with the most. There are several sets of trials, and it used to be more the case with efficacy trials, wherein those characteristics I put up about the typical population in need are people who would be screened out of the trials themselves. So if you have low literacy, or if you already have advanced complications or comorbidities, you just weren't a part of the trial, or if you have transportation issues and can't get to the trial reliably, you're already screened out. And so to the extent that I think research in general in the field has moved towards more pragmatic trials, more real-world trials, where you are to enroll the people who are really there and under care, help us avert some of those issues. So I think that's critical. If you publish your paper and it says people are in poverty in this randomized trial, it gets more attention than a trial where everyone had a particular socioeconomic status or doesn't reflect that organization or that stakeholder's population.
And it prevents we often hear the comment from practitioners, the people that you evaluated in your study are not the people I treat.
That's right.
But you address that issue if you keep it that broad when you do it a pragmatic trial.
Absolutely so, because it's almost impossible. If the researcher isn't able to provide the intervention manual and the training, it's almost impossible from the recipient, the stakeholder side, to have a training intervention module, plus it would have to be completely revised for their population. Now the evidence base is gone.
Right.
Excellent. So some of the questions that we're getting from online are, what is your thinking about the need for behavior change in healthcare providers in adopting these new pathways of practice and making them work not just in theory but in actuality? And are you working with any systems to change healthcare provider practice?
Right. So a lot's happening already with changing provider practice, and certainly the care quality metrics, when those are fed back to providers and the incentives and disincentives, I've observed these have certainly awakened providers to thinking more about whether or not something needs to be changed in their own practices, right? So before, when, it's very easy to think about the patients who you see regularly, and so your recent memory and your evaluation of your own care may very well be based on the people who come in all the time, and they're doing okay. They really are. When you see your panel of attributed patients and you see names that you don't recognize because you haven't seen them or they haven't been here in 5 or 10 years, yet you are penalized for their health outcomes, it brings a different level of awareness. So what I have seen is that providers are eager to be able to do things that work and are effective, but they only want what they do not want the burden of being expected to be the sole person who can do what works. And so this thinking about team care in general, not just in the collaborative care model, but the thinking about team care, the thinking about these expanded workforces is very, very attractive to providers, because if providers can maintain a very clear scope while you have case managers who've gone through training who deliver X, Y, and Z, and you have your educators or you have your behavioral folks, it enables transformation to occur without it resting solely on the shoulders of a provider. But this is new. This is new. Very often reimbursements are reserved only for physician providers and then some carve-outs for other types of providers. So the fact that a case manager can get reimbursed, a community health worker can get reimbursed, a lay person who's the health ministry advisor at a church can get reimbursed, changes the game.
We summarized our approach, both to analysis.
Can you please mute if you're online? Thank you, we can hear you. So excellent. The second question is, let's see, or another question is, do you think we need to place a greater emphasis on cost effectiveness outcomes of health-related behavioral interventions? And I think one of the interesting things that I'm going to add to this question is you did such a nice job of talking from basic science all the way out to, real-world implementation and changing healthcare systems. Where in that, I see you're nodding your head, so my guess is yes, you think we should place more emphasis, but where in that continuum and how should we be thinking about it across the translational spectrum?
Yeah. So there are a few places where costs are essential now for researchers. And I struggled with, do I do a whole section about costs? There's no time. So thank you for asking the question. It is essential for a researcher, upon conclusion of a study, to know how much the intervention cost. It's just essential information. You will get asked the question. And so the most appropriate methodologies for determining cost are critical. And I don't know that we have clear guides for behavioral and social science for researchers reliably to use a methodology that will end with a cost metric that is interpretable across studies. That's critical. We have to be able to interpret costs in a reliable way across studies. Second, that metric must translate directly into healthcare, real healthcare. And so we have to think as at some point, I'm looking at BSSR people, as this scope of work begins to define the methodology for that cost metric, embedded needs to be those questions that the stakeholder asks us that we need to be able to answer. We need to know the costs for our personnel. And the costs may be different for, different levels of personnel, but what are the time costs for this? What resources? What are the differences based on setting? These are all things that we can do, and researchers do it all the time. I mean, it's rare now that researchers don't build in cost effectiveness as something they're going to look at, but we don't have that reliable, standardized methodology so that we all know how to interpret what that answer is and pass that on to the stakeholder.
Terrific. So one person writes in, was really impressed about thinking about kind of these fundamental principles and their application to other conditions, and was wondering sort of what is your vision for kind of new conditions that are high priority to start to apply? The person that wrote in was talking about lupus, but kind of what else are, you know, are you and your systems kind of thinking about next steps? What are chronic conditions?
Yep. I'd say many healthcare systems, certainly many insurance companies, and I always include insurance companies because insurance companies have personnel. They have care managers, they have community health workers often now, they have health educators whom they employ to take care of their own insured population. So I want to include them too because they're all these sources. I'm sorry, I just forgot the question. Say it again.
Kind of other diseases, so
Yes.
the successes that you're seeing, like you did hypertension and
I forgot in that quick moment. As I paused to say insurers. So healthcare systems and definitely insurers have are able to identify their priority conditions, and often for an insurer it's going to be based on, you know, numbers of people with the disease, costs of the disease, billings because of that disease. From a healthcare system, it may be based on population size of the disease. It'll be based on quality metrics and performance with that disease. And so although there will be differences in different organizations, there are some overarching ones that tend to rise to the top, certainly diabetes, as we know, but cardiovascular disease, heart failure, CHF, kidney disease. That's another that rises to the top. But I would say any disease that requires self-management is where, in particular, behavioral and social sciences interventions can be helpful, and that's where these expanded workforces can really play a large role. Definitely lupus, definitely HIV.
What about pain?
Chronic pain, absolutely. Now, you know, in the chronic pain world, there tends already to be specific types of self-management interventions, but most providers don't know or use them. So I think those should be amenable to getting on that track toward integration and dissemination. Or they could see whether borrowing from some other interventions and putting chronic pain in as a module would work.
Excellent. So we've got time for one more question, and so I'm going to blend two implementation science questions that are here. One is asking about kind of frameworks or approaches that you think are particularly useful for capturing these kind of downstream outcomes. So what are the frameworks that you use or are most tied to? And then the second piece of that I think is somewhat related but also practical is when, and maybe you can pick which one you want to answer, is when designing and adapting behavioral programs, which factors often receive inadequate attention during the implementation phase? Like, you know, if you were cleaning for a day, what would be those things that you'd say, these are the things we should be measuring and attending to, and we're not systematically doing that?
Right. I would say the modifications needed to ensure that new population to which the intervention is being applied can receive the intervention. So for example, with the Medicaid National Demonstration Project, there were things that are not part of the standard DPP, but that our partnership with our Medicaid provider required, and that was transportation. That's not a standard part of DPP, but an insurer can decide if they're going to cover the cost of transportation. And again, the ROI covering transportation versus preventing or delaying type 2 diabetes, it may be worth it. Childcare, childcare costs, right? So those are just two, you know, some small examples, but I would say, and in different populations, it's different things. But I would say the single most important thing to pay attention to is whatever the factors are that will impede that population receiving the intervention itself. Because again, if we've done our job, we know that if they receive it, it's going to work. We know if they receive it, there's going to be some benefit to it. So we want to make sure they're receiving it.
Excellent. Well, I'll turn it over to Dr. Riley to close.
Thank you. Thank you, Christine, Erica, Deborah, for facilitating this. Felicia, thank you so much for your presentation. Much appreciated. And again, thank all of you who joined online today. We had a record sort of turnout for today's webinar. This is actually the last webinar for this year. So stay tuned to our website because we'll have a slate for the next fiscal year coming out fairly soon. So just remind you of that. Also a quick reminder that our annual Behavioral and Social Science Research Festival will be Friday, December 6th at the NIH campus. So just remind you of that also on the website. And the other, of course, final reminder, the recording from this will be available in about 2 weeks. So if you'll go online a little later, join our email alerts and do that sort of thing, that would be great. And and the link to sign up to receive updates is available as well on the homepage of our website. So thank you all. Thanks so much again. Thank you for the time and effort and presentation. Much appreciated. Thank you all.